got to kind of reconsider how that injury is presenting, what's going on. So if it's the LCL, then I'm probably going to have to step back and look at biomechanics. A, on palpation, make sure I've got the right structures in my mind under my fingers.
Okay.
So that it is, in fact, the LCL that I think I'm pushing on. And that's not too difficult because that LCL is pretty identifiable. Unless it's the ALL, which you never know. So, so MCL here, if we end up having issues or pain on the MCL on palpation and we're getting no opening of the joint but maybe tenderness on a valgus stress, then you might want to consider that you've got an excessively tight hamstring in your differential diagnosis, that seminal membranosus attaching into that location is going to give you the means of having pain there. And so if you can release the tension off of that, you can release the irritation and you can actually resolve that problem fairly simply without too much concern. You'll see that more often in heel strike than you will with midfoot just because of the biomechanics, and we can have that conversation some other day. Cartilage in the knee, the meniscus, two shapes, which are which? Yes, ma'am.
For the new one, for the ALL, it runs with the ACL?
No, it actually runs with the LCL.
Oh. Wait.
So,
What is the origin and insertion of that one?
all right, so this is the IT band. I'm going to hide him out of the way. There's my biceps femoris. I'm going to hide him out. And there's Longhead. I'm going to hide him out. So right here we have the LCL. Okay? So that new ligament, they're saying runs... Okay, this right here is a landmark called Gerdy's tubercle. It's actually kind of up underneath there, that tendon insert, that muscle origination is there. Okay, so what we've got is from where that LCL goes down to Gerdy's tubercle, they're actually saying that there's a ligament that sits right there. So about the same spot on the lateral epicondyle as the LCL origination, but it comes diagonally forward, and you can imagine that this is for rotary stability, so that it will prevent that tibia from rotating medially.
Is it like an extension of the LCL, or is it just its own name?
Well, they gave it its own name, so obviously it's its own ligament. Now, one reason that this probably hasn't been identified in the past is, again, I mean, the LCL is extracapsular. It's outside the joint capsule. My guess is if I was to go in and dissect, I would find that the ALL is actually more of a thickening within the joint capsule and not a unique identifiable structure as its own entity. That it was probably missed because it's more just a reinforcement line within the joint capsule itself, which makes it more...
Well, but it's for ACL people that keep recurring.
Because if it tears, then it's going to create a rotary instability, which is going to give that shifting sensation. So I imagine if you tear your ACL and you damage this as well, I mean, we have the unhappy triad, right? So they're probably going to come out with a new name to where there's like the unhappy quadad or something. So ACL, MCL, medial meniscus causes a lot of rotary instability. We fix things, but if that ALL gets ruptured because that torque is too much, then we end up having a rotary stability where people still feel it shifting out because we didn't address this laxity as well. So it may not be the fact that we have an ACL problem, but we may have recurrent ACL injuries, recurrent multiple tears. I have somebody who's torn her ACL graft twice. And so it may be along the lines of this kind of a mechanism to where we've lost rotational stability from having torn this as well and didn't deal with it, so we still have some functional deficits. Make sense? All right.
It's good enough.
What else do we want to do to you guys? Adductors, what are they? How many? How many hip adductors? 1, 2, 3, 4.
74.
5. Good job. There's 5. 5 hip adductors. What are their names? We've mentioned one already. The most distal inserting gracilis goes longest. Then we have what? Adductor brevis, longus, magnus. Pectineus. So there's pectineus. There's longus. There's magnus. Oh, and I made gracilis go away, didn't I? pull gracilis back. He's hiding up in there. There we go. And then brevis is tucked up and hiding underneath as well. He's kind of deep to longus. There we go. There's brevis. He hides. More often than not, we kind of think that a groin strain is coming from an adductor longus bolt. What? Adductors. Adductors.
You said brevis?
Adductor longus is going to be more often injured. They think from the clavicle. Femoral triangle. First of all, what are the borders of the femoral triangle? Sartorius. So, I already hit him off of there. Sartorius. Inguinal ligament.
Gracilis?
If I can get it. There we go. And adductor longus.
Wait, what was it?
So there, and there.
What?
Inguinal ligament, sartorius, and adductor longus. Oops, not that. What travels through the femoral triangle?
Femoral artery.
Femoral artery.
And the nerve.
And
There's like a sciatic,
it's the navy, the nerve, artery, and vein. The femoral nerve, femoral artery, femoral vein. NAV, navy, right? Got it? Nerve, artery, and vein. You're so vain. All right, hip flexors. Hip flexors.
Iliopsoas.
Iliopsoas, which are what muscles? Psoas major, psoas minor, iliacus. Good. So, psoas major, psoas minor, iliacus. Excellent. Oh, but there's one more. Rectus femoris. So the one quad muscle that covers two joints actually has an action on that first joint. So rectus femoris crossing over right there has action as a hip flexor. Differentiating between those two is going to be something you're going to deal with in lower eval. Real simple test called the Thomas test.
You're taking that right, right? Okay.
Next term.
Are you taking hematology?
Uh-oh. Let's go on the back side.
Sorry.
Oh no, we can
Just
pause.
keep
We'll
up
get
with
a lower
what's
leg
due.
first. Lower leg, what are my compartments?
I don't know.
Lateral, posterior deep, posterior superficial, anterior. Good? So the smallest of those is the lateral. What are the contents of the lateral compartment? Probus, longus, and protus brevis.
Is there only two?
Yes.
Those are the only two in the lateral compartment.
I forgot what.
I thought there was two.
There is a happy nerve that takes care of those two muscles.
Peroneal nerve. Is that right?
That's not it. That is.
Can't tap it.
There you go. Superficial perineal, superficial fibula.
Cerebral.
Superficial fibula.
Superficial fibula. The blue one right here.
What is that? What is it?
Superficial perineal or superficial fibula.
Oh, what is it?
Superficial
The
fibular.
nerve that goes to the peroneus longus, peroneus brevis.